A very warm good morning to everyone, and thank you all for joining us for today's webinar. It's a little bit housekeeping for all the participants. Participant, please mute your audio and switch off your video during the presentation. And if you have any query, you can drop your question in the chat box. We will get back to you after completion of the scientific session. Myself, Suchismita Giri, MSc tutor, faculty of SOM Nursing College, deemed to be University, feeling privileged to introduce our speaker, Professor Dr. Daisy Abraham, PG College of Nursing, Bhilai. Ma'am has 26 years of teaching experience and she is a university topper in BSc as well as MSc Nursing. She is a woman of virtue and simplicity who got many awards like Hospital Day Award, Jawaharlal Nehru Award, Susila Gidnikar Award, and 4 Excellent Award for Best Ladies Team at National Convention of Quality Circle. She has various publications in international and national journal in her credit. So now, without further delay, I would like to hand over the session to Mrs. Daisy ma'am. Ma'am, please. Hello. Hello, ma'am. Is it audible to you?
Yes.
Hello?
I'm just joining. Good morning to all of you. Am I audible, madam? Am I audible? Madam, am I audible?
Yes, ma'am.
Ma'am, your voice is not audible, ma'am.
It's not audible?
Am I audible now, madam? Am I audible now?
Yes, ma'am.
Yes.
You are audible. Yes, ma'am, you are audible now.
Okay. Thank you, madam, for a kind introduction. Is my screen visible to you all?
Yes, ma'am, screen is visible to you.
Okay. Thank you, madam, for the kind introduction. Before I start my topic, I take this opportunity to express my heartfelt thanks to the whole of the organizing team and Pravati Tripathi, madam, for inviting me as a resource person in your international newborn celebrations. So let's start the topic. My topic, which is okay. The topic which is assigned to me is quality improvement in neonatal care. Now, in this topic, we shall be basically studying what do you mean by quality improvement initiatives. We shall be studying the definitions. We shall be studying the quality improvement initiatives, which has been there in different areas. We shall be discussing approximately 12 areas. We shall also be studying about PDSA cycle, which is the method how we do this quality improvement. So these are the things which we are going to study today. Now, neonatal morbidity and mortality is a global public health challenge. And in case of India, if you compare the challenges much more. The neonatal period or the first 4 weeks of life is the very vulnerable period and where you have the maximum morbidity and mortality in this period. Okay. So the NICU, which we see now, was not existing in the 1960s, and the specialty of neonatology, it did not begin in 1970s. So the reason why we have this NICU is in America, when John F. Kennedy was president, he had a son who died when he was born at the age of 34 weeks. Okay. So there, because of the immaturity of the lungs, the child died. So the pediatricians who were there in US, so they decided that many children, because they were born preterm, they were dying due to different issues related to prematurity. So then they started thinking of setting up a NICU. In that way, the NICU was set up. Okay. So by 1990s, many of the children who were dying earlier, many of their lives could save. And even though children were born even at 24 weeks of gestation, even their lives could be changed because of the setting of this NICU. Okay. So even though the knowledge and skill in NICUs or in neonatal care, they from 1970s to till date, we have great advancement. Even in spite of that, we have still children who are admitted in NICUs. Okay, so when these children are in NICUs, what happens is they are exposed to different stressors. And what are these stressors? These stressors can be light, can be noises, can be exposure to different infections. There is a high risk of accidental extubation, etc., etc. Okay, so when the babies are exposed to this risk factors, it is very detrimental to the growth as well as to the neurodevelopment of these babies. Kept in mind is many of these causes of these risk factors are preventable, and if we adopt proven quality improvement initiatives, the neonatal care outcomes can be increased. Okay. Now this quality improvement, this helps to translate the best clinical and scientific evidences into clinical practice. You know, what do you mean by this? I will give you an example. For example, suppose in UK, somebody does a study, and they have studied that if they use pacifier activated music player, pacifier activated music player, I will be talking about this in my later slide. So they sorry, so they studied that if they use this, the feeding of the preterm improved drastically. Okay, so this is the finding, and they have evidence for that, and this is a scientific finding which is there in UK. Okay, so any study which is done in one place, so that finding, because it is evidence based, can be used not only in India but in other countries as well. So because it is evidence based, we can adopt those findings to as far as possible. And what is the advantage? The clinical practice will be improved. Okay, so in this way, what we are doing by quality improvement is we are translating the scientific evidences into clinical practice. Okay, we can adopt those findings to as far as possible, so that the neonatal care in our country also is also improved. Now, when we have a better quality of care, this is the healthcare which is provided is safe. Why? Because we avoid the harmful procedures. It is effective because it is based on evidence-based practices. Next, it is patient-centered because it respects the patients as well as their preferences. Okay, here we will be focusing on the preferences of the parents or the significant others of the children who are admitted in the neonatal unit. Next, it is a better quality of care will be timely because it avoids unnecessary delays. I will give you a very simple example for this. For example, if you are in a neonatal ward, you touch the feet of the child and you also touch the abdomen. You find that the feet is cold, the abdomen is warm. So this indicates the child is already in cold stress, that is moderate hypothermia. So if you don't take a timely action, this child who is having moderate hypothermia now will soon have severe hypothermia, which can be even fatal for the child. Okay, so a good quality of care is avoiding unnecessary delays. Okay, it is efficient because it avoids wastage, and it is equitable. Okay, because it can be used in different countries and different setups. Now we will study the definition of the topic, that is quality improvement. Now, what is quality improvement? Quality improvement is the combined and unceasing effort of everyone. Okay, combined means quality improvement cannot be done by one person. It is always a team effort. Okay, so many people will come together and do this. Second is it is unceasing. Unceasing means it never stops. It has to be continued. One quality improvement after the other. It is an ongoing process. Okay, now who does it? There are healthcare professionals. The patients and their families are involved, because we do this quality improvement among the patients and their families. Researchers are involved, payers are involved, planners and educators. All these people together, they have their combined effort, and what they do is they make some changes for three basic reasons. First is we want a better patient outcome. That is, the health of the patient has to be improved. Okay, the health of the patient is improved. Second is the care has to be improved. That is better system performance. And third is the learning will be improved. That is better professional development. So when we have quality improvement initiatives which are taking place, the three areas which are benefited is the patient's health will be benefited, the care what we give to the patient is benefited, and it helps in the professional development, because the quantum of knowledge what we gain after each of the quality improvement, that keeps on increasing. Okay. Now, these are the different areas. We will start with first area, that is pain assessment. Quality issues related to pain assessment. Okay. Now, pain assessment is one of the most unrecognized elements of neonatal care. Okay. So many a times people don't even they don't even feel that a neonate might be feeling pain, but that is not the case. A neonate feels pain. Okay. So when we are insensitive to these issues, the result is we will not be sensitive to the changes which are taking place because of pain. We will not be able to identify. We will not be able to manage. So quality improvement interventions are basically focused on assessment of pain, and then followed by management of pain. Okay. So how do you know the baby is in pain? There can be fluctuation of heart rate. How do we know? We can see the monitor and we can check it. Second is there is increase in the cortisol levels of the patient's infant's plasma, increase in epinephrine and norepinephrine because of the stress which is involved with pain. There is increased sweating in the palms, which you can feel. And there are changes in oxygenation, which can be identified by the pulse oximeter. And these are the symptoms which are related to pain. Now, the stars which are posted in an ICU whenever there is a painful procedure, we have to be sensitive to these symptoms and take appropriate steps to manage the pain. Okay. Now, to manage pain, we need to assess pain, and there are different pain scales available. This is a study which has been done by Ravi et al. So they have done a study in tertiary care NICU. So what they have done is they have tried to improve their assessment and documentation by using a neonatal pain scale. So different neonatal pain scales are there. What they used is NPAS. What is NPAS? Neonatal pain, agitation and sedation scale. Okay. So this scale not only assesses the pain, but this also assesses the sedation as well. Okay. So this has two scores. One is a pain score as well as a sedation score, and they have 5 parameters. That is the crying, behavioral state, facial expression, extremity tone, and a vital sign. Each of it has 2 scores. That is, each criterion will be based on a total of 10. Okay. So once they used it, they found that there was a marked improvement in pain assessment and documentation after 2 years of using this intervention. So what is the importance of using this pain assessment? See, once we assess the pain, we will be able to quantify pain. See, this NPAS will give you 2 scores, 1 score out of 10 for pain assessment and 0 to 10 score for sedation score. So once you know what is the level of pain, you can take measures. Now, how to manage pain? Management of pain, we know that we have pharmacological interventions and non-pharmacological intervention. Non-pharmacological interventions can be simple, giving a kangaroo care. Giving a kangaroo care not only is involved in thermoregulation, but studies have proved that There is improvement in the pain perceptions of the infants. This reduces the crying. Then there is a facilitated tucking. What is facilitated tucking? What you do is you just keep your hand over the foot, over the foot of the child, or maybe over the arm, and support the child. By doing this also, studies have proved that this decreases pain during endotracheal intubation and also during heel pricks. Okay, even non-nutritive sucking, this also decreases pain, and studies have proved that glucose is better as compared to sucrose. Okay, different types of massage is available. For example, if you give 2 minutes massage before a heel prick, so this decreases the pain scores. Okay, so different pain assessment scales are available. Depending on that scale, we can find out the level of pain, and once we find out, we can manage pain better. Okay, now is what should we do? The NICU staff should focus on pain management methods. First is reducing the number of painful procedures. So as far as possible, the number of painful procedures can be reduced. For example, if you want to take a blood sample, instead of taking 2-3 blood samples on a single day, it is better to have one prick and then take sample as much as possible. Okay. Then is treating post-operative pain immediately after surgical procedure, anticipated pain, and give it the managed pain. Okay. Next is preventing prolonged and repetitive invasive procedures. Okay. For example, if you want to have an endotracheal intubation, or if you want to have if you want to take a blood sample, so what we by doing a veni puncture, instead of asking a new person doing this procedure will be prolonged and multiple attempts will be required. So this increases pain more. Okay. So then is treating the acute pain with medications which have been proven safe for infants. So different hospitals, they have their own pain management protocols available. Depending on that, we can give pain medications. Okay. The second area is CLABSI. What is CLABSI? Reduction in central line associated bloodstream infection. Okay. So Ting et al., what they have done is they have followed a 10-step regimen. Okay. So what are those 10-step regimen for reduction of CLABSI? First is observing the existing practices. Next is conducting an awareness intervention for NICU staff. Okay. All of us, we may be trained maybe long ago, or maybe whenever we are trained, we all need repeated awareness related to different topics. So this improves our knowledge as well as skill. So what they did is they increased the awareness intervention related to the central line associated bloodstream infection, then establishing a skin preparation protocol to avoid skin injury, then cleaning of IV ports, tubes, and ampules, and proper central line insertion, maintaining sterile towels, gowns, and caps, then ensuring the availability of sterile surgical masks, then using disposable surgical blades, maintenance of central venous lines regularly, and following proper hand hygiene. So these are the 10 steps which Ting et al. They have used in their NICU. So what is the result? There is reduction in the infections from 7.9 to 2.2 per 1,000 catheter days. So that was the reduction when these 10 steps were taken. And the antiseptic which they used for skin was, they used chlorhexidine gluconate in alcohol, and neonatal skin preparation, whatever excess antiseptic was there, so that was cleaned, wiped with normal saline immediately after the disinfection, and iodine-based products were not used. So these are the protocols which they did in their study, and by adopting all these things, so the result was the CLABSI rate reduced from 7.9 to 2.2 per 1,000 catheter days. Okay. Now, other people have also done. So Bowen et al., they have done a study. So implementation of potentially better practices to reduce infection and providing awareness. So they improved their practices, improved the awareness. There was reduction in more than 50% reduction in infection. Okay. So Koppel et al., what they have done is they have used a closed medication system. Closed medication system in central line is using a needle-less. Okay, we have a needle-less technique where we can give the medication by lower lock. Okay, so central line will have two ports. One port will for the IV line, second will be for the medication. We will not be using the needle, but instead of needle, lock system is there. So that is called as a closed medication system. By this closed medication system, CLABSI rate was reduced by 92% over a period of 10 years. Okay. Then educational intervention, even if you can educate your staff. So this Bezzaro et al., they have done a study. So there was a significant reduction in CLABSI rate as well as the sepsis rate. Okay. So these are the quality improvement interventions related to CLABSI. Now, the third area is prevention of sepsis. So different studies are there to support this. So one quality improvement intervention and related to prevention of sepsis was this was done in Ohio in 24 NICUs. So what they reduced the frequency of late onset bacterial infections during 22 to 29 week gestations. So they used a collaborative quality improvement methods to implement evidence-based catheter care. Okay, so intervention there was reduction in 20% reduction in the length of stay. Okay, so even though if there is a 20% reduction of length of stay, if you consider the charges, suppose in US, 1 day stay of a neonate in an ICU can cost between $1,500 to $2,500. Okay, so whenever there is a reduction in 20% stay, this causes a great reduction in the financial burden. Okay, next is Bayard et al. They have demonstrated that CLABSI reduction, they could reduce the rates by forming a team which includes both doctors as well as nurses. Okay, so Bayard et al. Has told. Second is Harris et al. So what they have found is if you assign nurses instead of phlebotomists, who are phlebotomists? They are lab technicians who take out the blood in simple words. Okay, so they found that the rate of contamination was reduced by 53% when nurses were used instead of phlebotomists, and the rate was reduced from 5.19% to 2.46 microns. So this studies indicates that nurses are much more able to reduce the infection as compared to phlebotomists. Now, with topical emollients. Emollients are those agents which we use to prevent the skin injury. So what it was found that if you use topical emollients, they increase the risk of nosocomial infections, especially staphylococcal infections. Okay. Then probiotics. Probiotics are good bacteria which improves the gut. Okay, so that are probiotics. They are good bacteria. Okay, so by giving probiotics, the necrotizing enterocolitis, that is NEC, they are reduced because they contain anaerobic bacteria. Then fluconazole. So fluconazole, if you used, it was found that there is decolonization in invasive candidiasis. And lactoferrin, if it was given orally, this not only prevented the sepsis, but also there was a reduction in necrotizing enterocolitis and also in the development of late onset sepsis. Okay. Now, the fourth area is prevention of necrotizing enterocolitis. We know that necrotizing enterocolitis is more common in preterm infants as compared to a term infants. Okay. So quality improvement practices is first is delayed cord clamping and cord milking. Okay. So cord clamping was delayed by 30 to 60 seconds. And so by doing this cord clamping, what was the advantage? There was improvement in transitional circulation. There was better establishment of RBC volume. The need for blood transfusion was reduced. And there was reduced incidences of NEC, that is necrotizing enterocolitis, as well as IVS, that is intraventricular hemorrhage. Okay. So cord clamping was done at 30 to 60 seconds after birth for vigorous term as well as preterm infants. Now, what is umbilical cord milking? Umbilical cord milking is a procedure which can be done in the cord. We clamp the umbilical cord, and the blood is pushed towards the baby or towards the infant 2 to 4 times, and this has to be done within 20 seconds. Okay, within 20 seconds of birth, what we do is we grasp the cord and push the blood 2 to 4 times towards the baby. Okay, within 20 seconds. So that is cord milking. Okay, so by doing this, delayed cord clamping by 30 to 60 seconds and cord milking has helped in prevention of NEC. Then is standardized enteral feeding guidelines. This is according to the different protocols what we have. And next is, whenever you have a feeding guideline, it is better to give exclusive feeding of own mother's milk. Okay, but if this is not available, then we can use donor human milk. So never use formula feed for NEC, because it has been found that formula fed babies have increased chances of NECs. Most probably it is 20 times increase in NSC as compared to breastfed infant. So breastfeeding is recommended for NEC, but breastfeeding preferably from the own mother, and rather than using donor milk. Okay. Next is feeding guidelines during a packed RBC transfusion. See, there is a NEC which is called as TANIC, that is transfusion associated NEC. Okay, so after blood transfusion, the baby develops NEC after 30 days. Okay, so studies have proved that if you don't give feeding during transfusion, then the chances of NEC are reduced. Okay, so these are the findings in relation to transfusion associated NEC, that you withhold feeding during transfusion so that the NEC which occurs due to transfusion can be reduced. Okay. Next is use of probiotics also have contributed to prevention of NECs. Okay. So there are different studies. First is Rabe et al. They have studied, it is a Cochrane review among 738 infants. So they have studied in relation to delayed cord clamping. So there was lower risk of NEC. Okay. So this was done in 5 trials involving 241 infants. Okay. Then is Talaver et al. So what they have done is they have a quality improvement initiative in terms of standardized early human milk feeding, conservating feeding guidelines during blood transfusion. Next is indomethacin treatment. Indomethacin is the drug of choice for a PDA, that is patent ductus arteriosus. So studies have proved that if you give indomethacin, the chances of NEC increases. But instead of indomethacin, if you give ibuprofen, so the chances of NEC, ibuprofen also can be given for PDA. Okay, so the chances of NEC is reduced. Then is restrictions of ranitidine use in very low birth weight infants. So studies have proved that if you give ranitidine, which is a histamine receptor antagonist, if you give Rantac, the chances of NEC is increased. Okay, so there are studies that see very low birth weight infants has to be fed by tube feedings. Okay, so studies have been compared between the contamination rate of infant feeding tubes with ranitidine and without ranitidine. So it has been found that there is more contamination with ranitidine as compared to as compared to those babies who are not given ranitidine. Okay, so why this was so? Because histamine receptor antagonists, they reduce the acidity of the stomach by decreasing the hydrochloric acid, and by decreasing the acidity of the stomach, the growth of bacteria increased. Okay, so with if the baby, very low birth weight infants, ranitidine should not be given, because this will increase the rate of infection. So these are these all things they incorporated in their quality improvement initiative. The result was significant reduction in NEC from 8% to 3.1% after this strategy. So this is So this is how the loops, NEC intestinal loops looks. Okay. Next is next again a recent Cochrane review study. They have used probiotics. So this decreases both overall mortality as well as incidence of NECs. Okay, so they found that when they gave probiotics, the incidences of severe NEC was reduced. It was a very last studies of 20 studies involving 5,529 infants, and mortality, it also decreased mortality based on 17 studies involving 5,112 infants. Now is hand hygiene. Hand hygiene remains a cornerstone for infection control practices. Okay, so infections can be cured by maintaining hand hygiene in relation to all these steps. We already know all these things because now we have hand hygiene day celebrated during the infection prevention week. Okay, so inserting a central venous catheter when you before this blood sample collection, treating and dressing of wounds, changing a parenteral fluid, giving drugs through IV. Next is maintaining a central line, suctioning through endotracheal tube, prolonged contact with infants when we are bathing, maybe changing position or giving physiotherapy, or you are taking a vitals, or you are giving some drugs through oral route, or giving tube feeding, or having a skin contact while changing diapers. These are the common procedures which requires mandatory hand hygiene before and after the procedures. Okay. Of diapers, intubation, etc. Okay, so Floyd has suggested some intervention for to reduce the infant stress. First is maintaining an infant-friendly environment in NICU, including reduction of light and noises. So whatever light noises are there, so that has to be reduced as much as possible. We have to be sensitive. Suppose if you are talking also, we can talk in loud voices, we can talk softly. We are working in near to reduce the noise. Okay. Next is care for neonatal development. This we have to improve the mother-infant interaction as far as possible. Skin to skin care, that is encouragement of KMCs for stable babies. Improving social interaction has to be improved. Then improving the suctioning technique. Okay, all babies do not need suction. Okay, many of times people feel that you have to suction all babies. It is not only, it is not mandatory at all. So suctioning is to be done only if the baby requires shows the symptoms of suction. And whenever we do the suction, you must have learned in your NRP's neonatal resuscitation program. So the baby's neck has to be maintained in sniffing. Just improvising the admission process in NICU. Only those babies who require intensive care, only they have to be admitted in NICUs, and the admission procedures, that is the admission formalities, has to be done in such a way that the exposure of children, that is chances of getting hypothermia, exposing to more light, everything has to be managed in such a way that the stress can be reduced. Okay. So to reduce this stress, Vignocchi et al., what they have demonstrated is aquatic physical therapy. What is aquatic physical therapy? This is given by physiotherapist. There is warm water available for stable children, clinically stable infants. So physiotherapists gave this aquatic physical therapy, and they found that the sleep cycle and reduced pain, crying, and agitation movement of the infant was reduced. Okay, so this was findings of Vignocchi et al. Okay, then there is a meta-analysis. What do you mean by meta-analysis? You compile the findings of many of the studies, so that is called as meta-analysis. So they have various studies have been done in music therapy, and they have found that this helps in promoting the neurological maturation, oxygen saturation, and reduction in the length of days. And not only this also promotes independent breastfeeding. So this was all the advantages when music therapy was given. So these are all studies which have their evidence base in all these areas. Okay, by giving music, these are the advantages. Next is prevention of unplanned extubation. Extubation is the endotracheal tubes comes out. Okay, so Weldman et al. They have found that the most common reason for unplanned means without planning the endotracheal tube is coming out. Why the most common reason was the fixation of the end tracheal tube that was not done properly. Second, it can be an active or agitated infant, because of which the tube comes out. Okay, so they found that 75%, even if there is a accidental extubation, the tubes comes out, 75 babies do not require a re-intubation. Okay, they found that 41 children could be managed with nasal CPAP, and 33% they didn't require any respiratory support. Re-intubation was required only in 25% of the infants. Okay. Next area is prevention and management of hypothermia. Okay, so Harar et al. So they have a multidisciplinary guidelines for those children who are born before 35 weeks. We know that preterm infants have more chances of hypothermia as compared to our term infants. Okay, so what they have done is they have increased their operating room temperature. They take 10 minutes auxiliary temperature, and they use exothermic which have sodium acetate gel, and there is a metallic disc in this. So metallic disc, this sodium acetate gel, it crystallizes and it gives a latent heat. So that type of mattress is called as exothermic mattresses. Next is use of polyethylene. Polyethylene wraps are plastic bags. Okay, so this plastic bags has to be of this wrapping. This reduces the evaporative heat loss, convective heat loss, and insensible heat loss. And because of this, plastic bags are very useful to prevent hypothermia. Okay. Now, by using all these things, the incidence of hypothermia was decreased from 63% to 30%, and moderate hypothermia decreased from 29% to 9%. Okay. Next, MRI, magnetic resonance imaging without sedation. We know that during MRI, we want the baby should not move, and we need to sedate the babies. The problem is, if you sedate the babies, especially preterm, it is associated with significant morbidity and mortality. The cardiovascular as well as the respiratory system is also having an adverse effect. Apart from that, there is respiratory depression, which is characterized by hypoxemia, apnea, and hypoventilation, and there are potential hazards of MRIs. Okay, so what we need to do here is people have developed a technique to do MRI without sedation. Okay, so Stakovsky, LA, what he told is to use a MRI compatible incubator. Okay, so I will be showing the photograph of it in the next slide. So MRI compatible incubators are available. So proper training can be given to the staff, and they can use this. Okay, these issues can be reduced. Sedation, MRI can be taken. Second is Hani et al. what he suggests is to use a vacuum immobilizer. Okay, in the next slide. So once they use it, they found that this vacuum immobilizer, the 94% could have their MRIs with this vacuum immobilizer without sedation, and high quality images were obtained in 97%. Okay, so this was the advantages. Okay, I will be showing you the picture. So this is MRI compatible incubator, and this is vacuum immobilizer. There are different straps available, and this is a picture of baby after this is wrapped over. So what you find is different wrapping is done. We want the baby should not move. So what happens here is you wrap this and tuck the baby, and when you switch it on, air goes inside all these spaces, and the air will not crush the baby, but air will be so much that the baby is unable to move. So that is called as vacuum immobilizer, and they found that 97% high quality image, and by doing this, this sedation was not required, which is very detrimental to the babies. Okay. Apart from that, family-centered care is also advocated. So whenever there is family-centered care, because whenever the babies are discharged from NICUs to the ward and from ward to their homes, so there are some competencies which has to be done, which has to be taught to the family members, so they can be taught, so that and this has it has been seen that this has improved the neonatal care outcomes. Okay. Now I was talking about PDSA cycle. What is PDSA cycle? Plan, do, study, and act. Okay. So this is a 4-step arrow. This continues. Okay. So if you're not satisfied, this will continue again and again. I will give you an example for this. Okay. So PDSA cycle is for testing a change. First is you plan, that is you develop a plan to test. You want to change something. For example, your CLABSI rate was 21%. You want to reduce that. So that is a plan to test the change. Now you do a test, how to, you plan some interventions, and you observe and learn from the consequences. Okay, you use the CLABSI rate and determining what modification should be made to the test. Suppose if you're not able to get the desired results, then what modifications can be done. So it is a continuous process which is called as plan, do, study, and act. I will give you an example for this. See, I'm showing a quality improvement study, which is by using a PDSA cycle in Bangladesh. Okay, so 39% of the babies were found hypothermic after 1 hour of life. Okay, so I know we know that having hypothermia is very detrimental, and 39% is quite a high figure. Okay, so their aim was to reduce their hypothermia from 39% to 0%. Okay. So what they used is they used a PDSA approach. Okay. So by PDSA approach, they could able to do this. So they had 3 cycles. First is they formed a team which include 2 doctors and 3 nurses, and senior staff nurse was selected as a team leader. Here, one thing to notice: doctor is not the team leader, but the nurse is the team leader in this study. And PDSA cycle 1. So what they did was adequate covering and delayed cord cutting. When this was the step which they did, and they found that by doing this step, from 39% it was reduced to 25%. But their aim was to reduce till 0%. So they planned the second cycle. So they delayed vitamin K injection and weight recording within 90 minutes of the birth. So they shifted the weighing machine to it was first in labor ward. So they shifted the machine in the ward, and by doing this step, they found that 18% of the babies were having hypothermia. Okay. Then they planned the third PDSA cycle. That is, they improved the skin-to-skin contact between mother and baby for at least 1 hour after birth. For 1 hour, skin-to-skin contact was done, and now there was 100% achievement. That is, there was 0 incidence of hypothermia. So this is how we use PDSA cycle, and it is a continuous cycle which goes on till we get the desired result. Okay. Now, what are the limitations? So whenever you are planning for quality improvement, there has to be trained healthcare providers who are directly related to groundwork have to be given knowledge. Okay, whichever people who are the for example, in this Bangladesh study, hypothermia, the nurses are the main people who are involved in preventing hypothermia. So whoever is involved, they have to be trained. Okay. Then is whenever you are making change, success will not come overnight. We have seen this study. It took 3 steps to get the desired result. Okay. Next is keeping the patients. Okay, when the aim is there, sometimes it will take sometimes a long time, and the patience of the members can go down. So this can be sorted out by having a weekly meeting and appreciating the every member's ideas for solving the problem. And there has to be team effort and motivation to work. Okay. Now, what is the conclusion for this topic? Quality improvement interventions are proven and have shown to produce favorable outcomes in preterm infants in NICU. I have quoted many of the studies, and they have found that if you take simple steps, okay, for example, I was talking about facilitated tucking. If the baby is having a heel prick, what you can do is you just keep your hand over the foot or maybe the arm of the baby. So this has reduced the perception of pain. Second is if you take 2 minutes to massage the heel prick area and then the baby is given. So this can this has reduced the pain score. Okay. So quality improvement interventions, reduction of hypothermia, many of the topics we have already discussed. Okay. So further large scale studies need to be carried out to support the available. We have some available evidences in different areas, but if some large scale studies are done, so that will be much better in to test the additional new quality improvement intervention. That every quality improvement goal ties back to improve the health of the population. We are interested basically to improve the health. We are interested to reduce the cost of per capita cost of the healthcare, and we are interested in improving the patient experience. Okay. So that was all about my topic. I hope all of you have understood the quality improvement initiatives which has to be taken in the area of neonatal care. Thank you for giving me the opportunity to speak on the topic. Thank you.
Thank you, Madam Tesson. It was really insightful.
Okay.
Thank you, ma'am. So now we'll move towards our next. I would like to invite our next person, Professor Medical College, Barampur, Pediatrics from College, and Fellowship in Neonatology from St. John's Medical College, Bangalore. Sir has published many papers in international and national journals. Sir has written many chapters in different books. Sir has attended many TOT programs like National Faculty Training Course for Advanced Neonatal Resuscitation Program at Bangalore, Regional TOT Training for Advanced NRP at Hyderabad, and State Level Training of Trainers Course on IMNCI, etc. As well as a trainer also, Sir has given many training on various topics like NRP, neonatal emergency, neonatal jaundice at different places. Sir is awarded with many awards like Best Award Paper for Periphery Doctor at Annual Conference of IAP in 2008. St. John's Research Society Merit Award for Best Research Work in 2010. Gold Medal Award from West Bengal University of Health Science in 2016. Sabaratna Samman Award in 2019, etc. Sir is a life member of National Neonatology Forum, Indian Academy of Pediatrics, Indian Medical Association, and Indian Society of Perinatology and Reproductive Biology. So now the session is about to you, sir. Please, sir.
Good morning, everyone. Can you see my slides? Good morning.
Good morning, sir.
I'm sharing my slides. Just give me 1 minute, please.
Okay, sir.
Hello.
Yes, sir.
Hello.
Yes, sir. Screen is
Are you able
visible.
to
Your
hear
voice
me?
also audible.
Okay.
Yes, sir.
Okay. So, good morning, everyone. There is a nice talk from Madam Desi about the policy initiative program. So, my topic is on neonatal transport, actually, which is very in stage of infancy in the state of Orissa, I can say. So, I'll try to give justice to my topic. What are the concepts? What can we go for in the state of Orissa? And what are the new ventures is available in outside Odisha and outside India also? That some overview I'll give. So I'll be just my main objective of my talk will be what are the practical constraints of the neonatal transport? What are the different types of neonatal transport? What should we do before transport? And what are the different modes of neonatal transport? And how we can improve upon the neonatal transport? So the practical constraints during neonatal transport, mostly in our setup, it is self-transport. Either the patient the newborn comes by the attendant with a taxi, rickshaw, or by a public transport. Most of the time, the ambulances 108 is not available, or when it comes, by the time the patient is very sick. And the facilities are also very scarce and not easily available. Families have poor resources. Then the transport services, the transport ambulances what are available in our state are not organized, are actually meant for most of the adult patients. It's not an organized neonatal transport service, what I mean to say. And most of the time, we don't have manpower. That means the doctors, staff nurses, most of the time, they don't accompany the baby. When we receive such a baby in a tertiary care NICU, we face a lot of difficulties because there is no accompanying doctor or staff nurses, no referral notes are there. So the communication system is inefficient and non-existent practical in our setup. So these are practical constraints. So there are three types of transfer, I can say. One is intrauterine transfer. That is probably the best and safest for the unborn baby. Suppose from a peripheral setup, a newborn baby is going to be delivered. The mother is very sick. Mother is having a preeclampsia, gestational diabetes, or some other neonatal complications that we can anticipate if the baby is being delivered at peripheral setup. Like there is a twin pregnancy, there is an abnormal fetal position like breech presentation, transverse lie. So those babies we can anticipate. In a peripheral setup, it's difficult to handle those babies. If the baby is delivered, then the baby can have a problem of asphyxia, and therapeutic hypothermia is not available in peripheral setup. Suppose there is a fetal bradycardia we encounter in the peripheral setup, there is very high likely there is a risk of asphyxia. Similarly, suppose there is a placenta previa, mother has a premature onset of labor pain, that is preterm labor pain, then premature rupture of membrane, there is a hydros fetalis. So those babies, those cases we can anticipate. We are dealing with a very high risk delivery, and it's always best to deliver such a mother in a setup where all the facilities are available to take care of these preterm babies. If so, always it's better for the intrauterine transfer because inside the uterus, the amniotic fluid is warm. So the ideal temperature for the newborn baby. So inside the uterus, it is an ideal environment, both from the nutritional point of view for the newborn baby, also from the physical point of view. It maintains the temperature, nutrition, provision from the placenta. Similarly, just for example, one case scenario I need to give. Suppose a mother with a RS negative pregnancy, first pregnancy, in the antenatal period, in the second trimester, DCT is positive, ultrasound shows a hydrospitalis. So if this baby is going to be delivered in the peripheral setup, actually it is very difficult to manage such a baby. So only the knowledge of the doctor or the knowledge of the pediatrician or gynecologist is not important. So the peripheral setup has to have all the facilities to handle this baby. I remember one case of hydrospitalis we managed. Here at KIMS I managed one baby. So the baby has hydrospitalis with both sides pleural effusion, ascites, and both the mother is RS negative, baby antenatal they have done from outside, baby is RS positive, and there is a isoimmunization. So immediately after delivery, the baby was having respiratory distress. We two pediatricians were there at the time of delivery. Immediately after delivery, the baby was not able to take breath because of the huge ascites and bilateral pleural effusion. So in the delivery room itself, we have put 2 chest tubes to drain out the pleural fluid. Then we have already arranged blood for exchange transfusion, because by the time we checked, it was looking totally white because of the intrauterine hemolysis. So the point of telling is always intrauterine transfer is the best for the better outcome of such a very high risk delivery. And when we aim for by 2030, the target is a single digit neonatal mortality rate. But we have lot of essentials. Now, day before yesterday, we had a discussion on 17th November, that is the World Prematurity Day. We had a panel discussion. We had 40 essentials in the state of Odisha and 65,000 essential admission in the state of Odisha. But unfortunately, we have only 40 or 50 beds, NICU beds, I am telling. So essential can manage the level 2 babies. But NICU, those babies who are very preterm, less than 32 weeks, less than 1 kg or less than 1.2 kg baby, severely asphyxiated babies, they need care in a setup with all facilities. That is, they need a level 3 care. So unless the newborn is being referred to a level 3 care, then probably the baby is not going to survive in a essential setup which is not well equipped, even though the pediatrician is highly knowledgeable to handle that case. Okay, so those patients, unless they can be transferred to a higher setup or a tertiary care center, it will be difficult to handle. And this is one of the priority to develop tertiary care center in the state of Odisha and to develop a safe transport system for these sick newborn babies or who are sick unborn babies to a tertiary care center so that we can achieve the single digit NMR. So this is about the intrauterine transfer. Then coming to the intra-hospital transfer. Intra-hospital transfer means a baby, how it is transferred from the labor room to the NICU. So ideally, the labor room and NICU has to be close by. That means by side, it is the best. Luckily, in our some hospital, we have a labor room which is just adjacent to the NICU, but most of the areas it is not there. So ideally, it has to be in the same floor. Or similarly, the emergency department and NICU transfer. So these are the 2 intra-hospital transfer. Or second, suppose the baby in the NICU is there, he or she needs a echocardiography, ultrasound. So we cannot expect all the ultrasound machine, echo machine to be there inside the NICU. We luckily have that. But again, that is a screening machine. For a definite diagnosis, we need to transport these babies to the cardiology unit for echocardiography or to the ultrasound, radiology room for an ultrasound. So how this baby is going to be transferred from the labor room to the NICU, or a sick baby from the emergency to NICU, or from the NICU to the radiology department or a cardiological department for the intra-hospital transfer, that is also the key for management. Suppose what is most important is the stabilization of the baby during the transfer. So unless we are able to maintain the temperature of the baby and stabilize the vitals of the baby, so the baby may grasp. As we know, my teacher used to say, so the preterm babies are just like water bubbles. So you don't know the existence the next moment. Why? At that point, I'm telling, when we are doing post-graduation just almost 14 years back, that time any baby 1.5 kg or more we used to take care. Less than 1.5 kg, we told, no, this baby is not going to survive. And most of the time, believe me, we used to do a negative counseling because this baby is not going to survive. But that has gone now. So now we are successfully able to make the baby survive with almost 24 weeks or 505 grams. Last 2 years back, we have safely discharged a baby with a 505 grams. Recently, we have discharged a baby with a 24 week or 23 plus 5 weeks delivery. So unless this stabilization from the labor room to NICU or from the emergency to NICU is maintained, then only you can have a very good outcome. Suppose a preterm baby, a 26 or 27 week or baby is delivered in the labor room. The most important part or crucial part or the weakest link we tell, as you know, there is a warm chain and a cold chain. So during transfer, we tell it is a cold chain. During vaccine, we tell it as during transfer of a newborn baby, we tell it as a warm chain. Vaccines potency is maintained proper cold chain. Similarly, for the best outcome of a newborn baby, we need to maintain a proper warm chain. So these babies from the labor room to NICU, we have to bring the baby in a 6.5 to 37.5 degrees centigrade. Recent studies have shown the risk of neonatal mortality increases. Studies have already proven there is the decrease in 1 degree centigrade decrease in temperature at admission to the NICU. Then that increases one-third rate of mortality increases if you are not able to maintain the temperature in the 36.5 to 37.5 at the time of admission. So how we should keep the baby's temperature normal? So that we can do by simple maneuvers like wrapping the baby or shifting the baby through an incubator or through a warmer. That we'll discuss. Similarly, during the intra-hospital transport, suppose the baby in the labor room is having a respiratory distress or the baby in the casualty comes with a respiratory distress. So unless we shift the baby with a normal oxygen saturation, so that is always a problem at the time of the NICU. So what we used to do from the labor room to the NICU or emergency to the NICU, any patient who is having respiratory distress, we used to give respiratory stabilization with the use of a T-piece resuscitation. That machine is there with us, so that can control, that can improve the respiratory distress, that stabilizes the chest wall, that gives some positive end-expiratory pressure, that gives some positive inspiratory pressure, and that helps the alveoli to remain open, and that decreases the respiratory distress in newborn babies. So this is the T-piece resuscitator that costs only 40,000 to 60,000 rupees. You can tell it as a miniature ventilator. Okay, so that can be kept everywhere in every setup, and the transfer of the baby from inside the hospital has to be there with the help of a T-piece resuscitator rather than allowing the baby to be on simple oxygen. Because by giving oxygen, we can only maintain the saturation. But believe me, can we just decrease the respiratory distress by giving simple oxygen? We cannot do that. Because once the baby is having respiratory distress, unless we give some respiratory support, so how much time the baby can take the respiration at such a high rate? So what will happen? So gradually the baby will go from respiratory distress to respiratory failure. So it is very important for the respiratory stabilization of these babies. So next coming to the inter-hospital transfer. That is the most common scenario that we face. That is the referral of sick preterm babies or sick babies from a peripheral setup or from a secondary care setup to a tertiary care center for a better outcome. So these can be decided depending upon the expertise where you want to transfer. So all the tertiary care centers are not in Odisha are not equipped with a high frequency ventilator or a inhaled nitric oxide, which are higher forms of treatment. So from peripheral setup, we can give some CPAP or oxygen or any medication, antibiotics, IV we can give. But the baby, if the baby requires intubation, higher form of ventilation. So we need to decide. So the doctor on duty in the secondary setup, secondary level care setup, or a level 2 care setup has to talk to the center where the needed facility is there. Suppose the baby has a congenital heart disease. Okay, so the baby has a murmur. Clinically, the baby has a murmur. The baby has a cyanosis, which is not improving with the oxygen. So the secondary care center doctor has to decide to shift such a baby to a center where a pediatric cardiologist is available or where a pediatric CTVS backup is there. So in Odisha, only 2 centers have pediatric cardiology backup. So if the doctor is referring to a other tertiary care center, so we are not able to give justice to that patient. So it has to be important by the doctor what expertise is available, what resources is available in the tertiary care center. That has to be decided before shifting such a baby. And second, suppose it's a very critical baby which needs urgent intervention. Okay, so always it's best to shift to a nearby tertiary care center rather than shifting to Bhubaneswar or a higher center which is designed by. Are you able to follow me? Suppose in a CHC, a baby is delivered with asphyxia, baby has not cried after birth. Okay, baby has a convulsion. The doctor there has given a primary management for the convulsion. But unfortunately, what happens? The baby is not improving. The CHC doctor, the CHC pediatrician who is at community health center wants to refer the case. And the nearby hospital is a district headquarter hospital. And the tertiary care center is located in Bhubaneswar. So if it is always ideal to shift the person, to shift the newborn baby to the nearby district headquarters center, stabilize it, and then shift to a higher center if needed. Okay. Third, we need to know what are the road, communication, and transport facilities are available. So unfortunately, I'll just give some hints. The road transport, then air transport, all the options are there. But unfortunately, we don't have air transport facilities in our state. Okay, so we need to decide. But suppose the baby is very sick. Suppose the baby is very sick. We need to transfer, or a cardiac, suppose it is a cardiac cause. We need to transfer because to Delhi, the patient party is available. So we need to decide whether the baby can be transferred by a rail or can be transferred by a air. So if the patient party we need urgent treatment, the patient party is affordable, then we can plan for a air transport. So this is another factor we need to decide. Then another important thing is the parents' willingness, the affordability of the parents. Okay, because even if the parents' willingness will be definitely there, it's not an issue because who doesn't want the baby to recover? So the doctors, nurses, everybody wants the baby has to recover. Okay, so willingness should not be an issue, but issue is the cost of treatment. Unfortunately, till now, the government setup, it is all free of cost. But in the government setup, as I told you, only 50 to 60 neonatal ICU beds are available. So if they are dependent upon the private NICUs, then it is not free of cost. So the cost has to be borne by the patient. So the affordability has to be thought of before actually planning for transport. So here comes the role of insurance, role of the palpatory method. That means they toss the center, abdomen, and the periphery, that is the extremities. And if the center is warm and periphery cold, then we tell it as a cold stress. If the center is cold, then we tell it as a hypothermia. But ideally, it has to be through a digital thermometer. So during the transport, before the transport, the temperature has to be stabilized between 36.5 to 37.5, or the baby can be wrapped, or the baby can be, that is otherwise called a facilitated docking. Okay, or the baby can be maintained temperature with a kangaroo mother care. That means skin to skin contact with the mother, or if the mother is sick, the father or any attendant who is stable can do kangaroo mother care, so that the temperature from the mother or the attendant is transferred by skin to skin contact to the baby, and the baby remains warm. Just keeping a 1 inch of thicker shoulder roll behind the shoulder. So that will help the baby to remain, do simply suctioning of the airway to keep it open. Next, coming to the C, that is B. T, we discussed temperature, then airway. So we need to assess whether the baby has that is only increase in respiration. Along with increase in, we are not going to stabilize the respiration. There has to be a pulse oximeter connected to the baby. It is all available in the, and we need to target the saturation between 90 to 94. That is, in emergency, you have to go meet this doctor because you have already communicated, and whom to contact. Or you contact the casualty medical officer, so that it decreases the time for this baby. Then again, the facilities are available through the government. That is before transfer. You want to go to a government hospital, what is the finance status? So depending upon the finance status, they have to come to the government hospital or to the private setup. If the patient party is affordable and he wants to go to a private setup, then you can send them directly. But suppose the patient party is not able to afford for it, you tell no, you have to go to some hospital to, or King's Hospital to get. But patient party tells I don't. Our nice school. Just see how the lady attendant holding, and mother, this lady attendant is sitting over the cot, and the oxygen, the baby is being shifted out. Do you expect how much time it will take to put such an advanced stage where an advanced neonatal air transport is coming up? So we need to work upon this neonatal transport. Definitely, it is an evolving concept in our setup, and believe me, in advanced neonatal centers in outside India, even centers like Redbow Children's Hospital, in bigger centers, bigger private corporate hospitals in Lisa, again it is a evolving concept. This is just a picture 1 month before. Only luckily they knew my number. The baby has a complex congenital.
Nice. So kindly go to the feedback link and submit. Ma'am, now you can.
Okay. Thank you, Smita. I wish a warm good afternoon to all honorable speakers, so dear madam, faculty members, and dear participants. Child Health Nursing Department. I thank madam on behalf of Department of Pediatric Nursing, some nursing college. Next, I thank Geeta Rani Nayak, AIMS Bhubaneswar, for classes on perspective on promotion of kangaroo mother care. It was